Hello, and welcome to everyone joining us for this evening's Ask the Radiation Oncologist session, focusing on gastrointestinal GI cancers. My name is Dr. Jolinta Lin from Winship Cancer Institute in Georgia, and I'll be moderating tonight's session. Through this session, we hope to answer questions you may have about GI-related cancers. The panelists and I will be covering an assortment of topics ranging from treatment types, side effects, and more. We have a distinguished panel who will share their expertise in GI cancers with us. Today, we have Dr. Alexandra Diaz from the James at The Ohio State University, Dr. Chika Madu from Northwell Health in New York, and Dr. Terence Sio from Mayo Clinic in Minnesota. Next slide. The format for tonight's session will be a short presentation with some common questions that our doctors will discuss. This session is being recorded, so if you need to step away or log off, a recording will be available on this RTAnswers YouTube page and on RTAnswers.org website in the next 24 hours. To submit a comment on YouTube, please be logged in to your YouTube account. From your desktop, there's a live chat box to the right of the video where you can enter your questions. If you are on a mobile device, there's a live chat box below the video. Next slide. We encourage everyone to visit RTAnswers.org for more information on radiation therapy and GI cancers after the broadcast, as it is a great way to learn more and get access to additional patient videos, brochures, side effects, and more. Next slide. Finally, tonight's discussion is informational only and should not be used in place of advice specific to your condition from your medical professional. We will discuss treatments including surgery, chemotherapy, and others. We encourage you to talk to other specialists where appropriate about other treatments you are also considering. Without further ado, let's begin the session. Tonight's discussion will be focusing mostly on rectal cancer and anal cancer. Next slide. So first question is, what is a lower GI cancer? Dr. Sio, would you be able to help us with this?
Thank you very much, Dr. Lin, and welcome everybody to the Astro GI section. And with a radiation oncologist such as myself and also my panelists here, we deal with gastrointestinal cancer every day in the clinic for this purpose. With the gastrointestinal cancer, it really can be talking about from the beginning of the gastrointestinal tube, which is the esophagus, leading down to the stomach. And in the way of passing through, with the bowel and all that, we will see liver and also pancreas. That will go on and continue with colon, where the feces is being formed, until at the end of colon, that is being passed with rectum and anus. So with gastrointestinal cancer, it really can encompass a variety of different diseases.
Thank you for that. And Dr. Madu, would you be able to help us identify what the difference is between anal and rectal cancer?
Thank you again for having me on this panel. Rectal cancer and anal cancers are really differentiated by a couple of things. One is the location. So the anus is really at the very beginning. If you're doing a colonoscopy at the very beginning of the orifice, and then it's just really a short segment, and then you move on to the rectum, and then beyond the rectum, once you pass what we call the peritoneal reflection, then you're going into the colon proper. When we look at cancers, when we take a little biopsy and look at it under the microscope, the kind of pathology that we see with anus is typically different from what we see with rectum. So with anal cancers, we see mostly squamous cell carcinomas, and with rectum, we tend to see more adenocarcinomas, but that may vary obviously, from time to time. And then also, obviously, the treatment will be different for these cancers, but we can get into that much later.
So you're saying the distinction is really important, whether it's rectal and anus, because the treatment is different?
Absolutely. It changes how we treat patients. So if there's an anal cancer, the pathway is very different compared to a rectal cancer.
I see. And so how about a colon cancer? Do you see or treat many colon cancers then with radiation therapy?
So as radiation oncologists, we don't see much colon cancer, mostly because, with radiation, we typically aim at a target. The colon is constantly moving in space, so there really isn't much to target. So colon cancer is mostly treated by a combination of surgery and chemotherapy, and then radiation becomes more important when we're talking about rectal cancers and anal cancers.
Fantastic. All right, let's move on to the next slide. And Dr. Diaz, what causes rectal and anal cancer? Do we know the reasons why we see these cancers?
Thank you, Dr. Lin, and thank you again for having me as part of this panel. So there are different things that can be associated with rectal and anal cancer. So as Dr. Madu mentioned, the rectal and anal cancer are very different. So things that can be related to anal cancer those are cancers that are mostly related to a HPV versus for rectal cancer, which is adenocarcinoma, then we are more concerned, we have more risk factors. Risk factors include a constipation, a diet low in fiber. Those are some of the potential risk factors.
Okay, and Dr. Sio, how are lower GI cancers diagnosed, or how do people find them?
Thanks. So importantly, we are dealing with either a rectal cancer or an anal cancer. And this is where the distinction and the differences may come in, depending on where the primary mass may be located, whether it is in the anus, which is about 4 centimeters going in from the surface and the orifice, versus maybe the next 15 centimeters where the rectum is located before it turns and becomes the colon, which is a disease site that we are less, that we'll be dealing with less as a radiation oncologist. And in terms of the anal cancer, we focus on looking at the size of the tumor and also where the lymph nodes are being located. Oftentimes, a PET-CT scan should be performed, maybe also in addition to an MRI of the pelvis, which is being used more common now. For rectum, all the above testing is also indicated, including a full colonoscopy to make sure that there's no other cancers or nodules that are hiding in the rest of the colon. And importantly, for rectal cancer, if we are going to be doing a full MRI, then it may not be as much of a matter. But oftentimes, we are also doing what we call an endoscopic ultrasound to look at how much of the mass is penetrating through the wall of the rectum, which can be helpful in determining the staging and also the subsequent treatments.
Okay, very good. And can we go to the next slide? So then what happens after the cancer is found? I think you alluded a little bit to that. Dr. Sio?
Yes, yeah. So from this slide here, on the top, we see a CT scan, which is often a faster, quicker machine. And it is a quick scan. And oftentimes, we'll need to have the CT scan to be scanning through the pelvis and also in the abdomen and chest to make sure that and evaluate if the cancer may have gone to other organs, which will require additional therapies and methods for approaching it. The MRI of the scan often can be more space confining, and some patients of ours may find it more claustrophobic. And oftentimes, with an MRI, there is a device that may be placed in the anal and the rectum area, and that device will serve as an additional signal and method for basically making the picture more clear so that we can take a look at the images with higher resolution.
We have a question from the group. They said, I heard that the bowel prep for a colonoscopy can be unpleasant. Is it? Dr. Madu, would you be able to help us shed some light on this?
I can take that. Well, the bowel prep pretty much is designed to clean out the entire bowel. So if you're not a fan of sitting on the toilet for several hours, it's not going to be fun. However, it's tolerated very well. And typically your doctor will go through instructions on how to do the bowel prep. Most people do very well with it. And actually, I've heard this from some patients. They actually don't mind the process because they feel like they just got a detox session from the bowel prep, but it's tolerated well.
Well, that's good to hear. I think there's a follow-up question that says, do I need to do the prep if you already know that the cancer is in the rectum or the anal canal?
It is recommended because as Dr. Sio mentioned earlier, we also want to look at the rest of the GI system, the rest of the colon, to make sure that there are no other lesions that we need to be worried about. So with a good prep, when everything's cleaned out, your doctor is able to look throughout the entire mucosa and make sure there's nothing else.
Great, that's very helpful. And can we go to the next slide? Dr. Diaz, is there a way to prevent lower GI cancers and catch cancer earlier? Now you mentioned that there was some things associated. Is there anything that we can do to prevent this?
Well, so in terms of prevention, diet helps. However, something that I want to really emphasize is the importance of the using the screening methods once you reach the age to start screening, and consider not letting yourself be scared about the prep for the colonoscopy, because really that colonoscopy saves lives. So I really think that first of all, think that the earlier that the cancer is found, then the higher the probability of success of any treatment. And in addition, if you have the screening colonoscopy and nothing is found, well, think about it. You have 10 years that you don't have to get another one. So having screening procedures really, really helps.
And should I change my diet or take supplements during the treatment, Dr. Diaz?
I think if we are going to talk about treatment during treatment versus prior to treatment is a little different, and we are going to talk a little bit more about it. If we are talking about the diet before being diagnosed with cancer, how to prevent, so yeah, trying to have fruits, vegetables, trying to avoid processed meats. Is good. But if we are talking about the diet during treatment, we'll probably talk a little bit more about it later when we talk about the side effects of treatment. But because of the changes with radiation, it may be harder to have vegetables during treatment. So it's a little different, and I think we can talk a little bit more about it later when we talk about the side effects of treatment.
Okay, great. That's a good point. So let's move on to the next slide. So let's talk about the treatment of rectal cancer, or for rectal cancer specifically. Next slide. So we know that there are several doctors involved in cancer treatment, but which doctors are involved with patients with rectal cancers, Dr. Sio?
Yeah, so we're going to start with rectal cancer, and the anal cancer list is going to be quite similar too. But whenever I think about the specialist that needs to be involved with the patients for rectal cancers, I can think about the gastroenterologist to help us with procedures and other diagnostic needs. Can think about the medical oncologist who can help us, he or she, to help prescribe with systemic therapy and treatments. And there has been a lot of new evolution and new treatments that are on the horizon for that too. We think about the colorectal surgeon, that he or she can help us with performing surgery, which is a curative method for rectal cancer. And there are different types of surgery. And then, of course, finally, last but not least, is the radiation oncologist who can help prescribe X-ray-based treatments, just like us.
Okay, great. I think that touched upon the second question on here. So let's move to the next slide. And Dr. Madu, how do doctors know which treatment is best, or treatments is best for me?
Well, I think it really all depends on all the information that we gather during the workup of a patient. So as alluded to earlier, we'll do a biopsy, we'll have scans, and when we put everything together, typically those decisions are best made in a multidisciplinary tumor board, as you can see on the bottom picture, where you have physicians from different subspecialties talk about each patient's case, the imaging, the pathology, and their performance status. And together, we all come up with a treatment plan for the patient. So typically for patients who have an earlier stage rectal cancer, perhaps they go toward the pathway of surgery plus or minus chemotherapy. And for patients who have a later stage rectal cancer, typically those patients will end up needing some form of chemo and radiation therapy prior to surgery to make the surgery even more effective.
Thank you for answering both of the questions. So let's move on to the next slide. And Dr. Diaz, does everyone get all of them, chemotherapy, radiation therapy, and surgery?
Not everyone gets all of them. So I think, so as Dr. Madu mentioned, so we usually discuss these patients in multidisciplinary tumor board, where the surgeons are there, the medical oncologists are there, our radiologists, and us radiation oncologists are part of the conversation. So depending on the staging, there are different treatment options for patients. And but most patients receive surgery. The patients, so depending on the stage, it's possible that some patients receive chemotherapy up front, as we call now, total neoadjuvant therapy, having chemotherapy first and then chemoradiation, and then going for surgery. Or some patients that now there are, for selected cases, sometimes we have non-operative management where the treatment includes chemotherapy and radiation. Those are very selected cases. Or some patients, they pass standard of care, or some patients just have chemoradiation and then surgery and then chemotherapy. So all of these discussions are made as part of a discussion at a multidisciplinary tumor board with the input of all of the specialists to try to approach the patient, to try to find the best approach for patients depending on the stage and location.
Okay, excellent. And next slide, please. So Dr. Sio, could you tell us a little bit more about radiation therapy?
So radiation therapy is a main treatment for helping our cancer patients fighting their disease. And radiation therapy is basically X-ray. That is not that different than, for example, getting a chest X-ray or a CT scan. But these are basically invisible high energy that we can use coming out from a typical X-ray machine, that we use what we call a linear accelerator to help concentrate that amount of energy in a very focused way that we can shine at a particular part of the body to help kill the cancer cells. And specifically, the target of, like the radiation therapy for the X-ray is the DNA. And every cancer cell has DNA, which is kind of the main copy of the cells and the cancer cell for making it dividing and to make it become active and aggressive and can hurt the human body. If we can stop the DNA from growing and copying within the cancer cells, then we have a chance of helping the cancer cells get killed as a result of radiation. So after with radiation therapy, typically it is given, for example, 5 to 5.5 weeks with rectal cancer, maybe even a little longer. That over multiple days, we're hoping to kill more and more cancer cells and to increase the probability of killing some of these DNAs in the cancer cells, and hoping that it will work. And with the addition of chemotherapy and also surgery that we're going to be describing later within the hour, then we have a higher chance of trying to beat some of these cancers.
Well, excellent. And A question from the chat box, just asked, will I be radioactive from the radiation? Is it safe for me?
Yeah, this is a very common question that some of our patients may still would ask, and it is very normal to be considering that. So basically, with radiation that is given, for example, by a linear accelerator, and a picture of that can be seen from the slide right there. And the patient will be lying on the black carbon fiber table. That all the active radiation will actually be only given within the radiation room, which is shielded by lead and also concrete. They actually would disappear even within a fraction of a second. And by the time when our therapists are going back into the room to help with our patients getting on and off the table, and then for the patient to leave the radiation room and also the department, they are not radioactive anymore.
A common question that we often get from patients is, will the radiation be affecting my family or children around me?
Correct, yeah. And as a result, because of the way how we are delivering the radiation from an external method, and this is absolutely not a concern at all. However, from other disease sites that we may also be going through from the Astro podcast series, we may also be talking about internal radiation. For example, with radiation seeds or iodine therapy for prostate cancer, they usually come with some precaution for radiation safety, but that is outside the scope of our topic for this evening.
Okay, very good. And next slide, please. So Dr. Madu, why would patients get two treatments at the same time, like chemotherapy and radiation therapy? Wouldn't that make the side effects worse?
So typically, chemotherapy at the same time with radiation, the chemo helps act as a sensitizer for the radiation. So it actually makes the radiation work much better. So this question is right. It does make the side effects a little bit worse. However, they're very tolerable. During the course of radiation with chemotherapy on board, we typically see side effects that include things like fatigue. Some people may have some loose stools. Some people may have some urinary frequency. For most patients with supportive care, with making sure that we're, getting IV fluids in there, with making sure that we're modifying our diet, and then also making sure that we have some medicines that we can take to help control loose stools or diarrhea, it's really tolerable, but it helps us kill the cancer much better.
Okay, and Dr. Diaz, you touched upon this a little bit before. What if the cancer shrinks with chemotherapy and radiation? Do we still need to do surgery?
So there are selected cases where we may offer non-operative management, which means for patients, particularly patients who had very low tumors that disappear, and if they went for surgery, will require an APR, which is when they have to do a permanent colostomy. So sometimes it's considered non-operative management, which means just continuous surveillance with scans, scopes, MRIs. It requires very close surveillance to make sure that there is no disease recurrence, but we are doing it more in some selected cases.
Okay, next slide, please. So let's move on to the treatment for anal cancer. Next slide. Dr. Sio, how is anal cancer treated?
Yeah, so thank you so much. So now we have switched our focus from rectal cancer, which oftentimes would need to involve a surgery for more curative methods and intent for hoping for the best outcome that we can have for our patients. And this is very different than for anal cancer patients that we use a separate approach. For rectal cancer, we are mainly dealing with a type of cancer called adenocarcinoma, or a cancer that is coming from a gland. And oftentimes, historically, we know that it will take a surgery to help us maintain the highest level of possible cure for these patients, except for selected cases that Dr. Diaz-Pardo mentioned that we may be able to help observe more frequently and to make sure that the patient can truly avoid a surgery. That is different than anal cancer, which is typically based on squamous cell carcinoma, or a type of cancer with an origin that is closer to the skin. This type of cancer, for anal cancer, it is more curable by only radiation therapy and also chemotherapy. And sometimes, even if we are in the situation that we may be dealing with bigger cancers for the anal region, with chemotherapy and radiation given times, it can actually still shrink down and even disappear very nicely. So that's why, as a result, we know that it would be nice to be able to help focus on helping our patients to preserve their organ. So meaning that they get to keep their rectum and also anus. And in the majority of the cases, we will be successful in doing that and also help maintaining the higher rate of cure for anal cancer. So it is important that we are still keeping our colorectal surgeons in mind and also in care for our anal cancer patients, because we also need their help to look at how their anal function and the sphincter is recovering, and also for ongoing surveillance with scoping and other needs. So as a result, I think it is very nice that we are seeing the differences and compare between the rectal and also the anal cancers. And I look forward to learning more with you later in the hour too.
Okay, thank you for that very thorough response. And next slide. So Dr. Madu, what types of short-term side effects can be expected from radiation therapy to the pelvis? I know you mentioned some of them. Could you elaborate a little bit more?
Sure. So typically when we look at side effects from radiation, the way I always explain it to patients is, when you look at what we're targeting, our question is what's in the way? What are the normal organs that are in that area? So that's how we're going to get some of the side effects. So if you think about the pelvis, what's there? You're going to have bladder there, you're going to have bowel there. And those are the things that are going to cause the most primary, side effects during the course of radiation. And also because we have chemotherapy involved, that'll also affect the mucosa. So the biggest side effects we're going to see will be some bowel symptoms. So some loose stools, perhaps some diarrhea toward the end of the treatment course, frequent urination. That means if you typically urinate every 2 to 3 hours, perhaps you're now going to the bathroom maybe every hour, hour and a half. But those are really short-lived. And then once radiation is done, they start to taper down. Patients will also notice some fatigue, and that tends to become a little bit more prominent toward the end of the treatment course. Some patients may have some irritation of the skin. We call it maybe a light sunburn, also very short-lived, and that settles down with time. The chemotherapy pills could potentially cause a little bit of a drop in blood counts, and that also will start to recover once combined treatment is done.
Thank you for that. And Dr. Diaz, are there anything that can be done to minimize some of these side effects? I know you had mentioned changes in the diet earlier.
Yes, so usually when patients are undergoing radiation therapy, they see their doctor at least once a week just to go over recommendations, but there are some things that we can do. So to decrease the probability of diarrhea, for example, we usually discuss having what we call a low fiber diet, which is basically no vegetables, trying to have more like rice, potatoes. We also can use Imodium if needed during treatment. In terms of the urinary symptoms, we are usually able to help with a medication, particularly for men who are the ones who tend to have more issues with urinary symptoms. So sometimes we can give a medication to help to decrease the urinary symptoms. In terms of skin changes, so we usually check the skin to evaluate the changes, the radiation changes, and we can use some lotions to try to help. And if as the radiation, especially for patients with anal cancer, as the radiation, the skin changes secondary to radiation worsen, sometimes we have to use some prescribed lotions to help to, with antibiotic to help to improve the healing.
And someone's also asking, are there sexual side effects from radiation and what can we do about that?
So there are some potential long-term side effects in women and men. So for women, it's possible to have vaginal stenosis. So usually it's very important that after treatment completion, try to work with dilators, discuss the use of dilators with your doctor. And for men, there is a potential for erectile dysfunction and even dry ejaculate for some patients. Sometimes the erectile dysfunction responds to medications such as Cialis and Viagra. But if you have any of these side effects, discuss it with your doctor to evaluate ways to address them.
Okay, that's very good advice. And next slide, please. So Dr. Sio, how do we know that the treatment is working? What do we do to check on the tumor?
So that's a very good question. So for rectal and anal cancers, lifelong imaging and also follow-up with your oncologist doctors are very important. And depending on what type of treatment you may be getting afterwards, after the end of radiation therapy, some of the follow-up and check-in can also be done by our surgeons and also medical oncology colleagues. It often means that we will need to have scanning to be done at regular intervals, and perhaps at the very beginning, every 3-4 months. And then if things are looking okay and stable with imaging and the tumor is not coming back, then we may even stretch it out to about 6 months, every 6 months, to eventually every year. We count the time when a patient is receiving the last type of therapy, with that being radiation or the last cycle of chemotherapy or the last surgery. And that would be the timing for starting point for what we help with the patient with survivorship. And that is also the same time point that we will start beginning counting for 5 years, and to hopefully to see the cancer going away and being eliminated and with no sign of coming back. Then 5 years later, we look forward to celebrating with the patient that this cancer is truly being cured. But oftentimes afterwards, we will still be performing some guidance, some imaging checking or laboratory and clinical checkings, depending on the type of situation it is. And for example, according to what we use for like NCCN guidelines or other societies' methods for recommendations. So it can be difficult, like to kind of describe all the possibilities. It's like no one size fit all, but in general, we do want to, look at how we're doing with the treatments and how it may turn out for our patients in the future.
Okay, thank you. And Dr. Madu, what happens if the cancer returns? What treatment options are possible or available?
So obviously, our goal is to treat the cancer, make it go away, and not have it come back. But unfortunately, in certain patients, we may have a tumor recurrence. When that happens, it's really important for us to do that whole workup again to figure out where the cancer is, if it's just local recurrence or if we have distant recurrence. So if the cancer has come back somewhere else outside of the rectum or anus and it's gone somewhere in the body, then we're talking about stage 4 disease, and typically the primary treatment for that will be systemic therapy or chemotherapy. Once in a while, we may have a recurrence that's really local. Perhaps you can have a recurrence that's at the anastomosis, and anastomosis is really where, when you do the surgery, where things are sort of hooked back together. If it's local there, not anywhere else, then we still have a chance of perhaps trying to resect that area and also giving some chemotherapy again. And then sometimes you could have a recurrence within the pelvis, perhaps in the lymph node or pelvic sidewall. I think in certain cases, after you review how much radiation the patient had received in the past and how much radiation that area has seen, there could potentially be an opening to give further radiation, but all of that has to be discussed in tandem with the surgeon and the medical oncologist.
Okay, so it's possible that radiation could be given more than once, but probably a case-by-case situation.
That's correct.
Okay, and next slide, please. So now we'd like to open up for audience questions and additional discussion. So someone is asking, Dr. Diaz, what sort of screening can I get for rectal or anal cancer?
So we have different options. We have the colonoscopy, as I mentioned, that they are doing every 10 years if there is anything that is found. There are others like the fecal occult blood test that requires more frequent testing, the Cologuard test. Those are some of the screening for colorectal cancer.
Okay, very good. If there aren't any other questions, then we'd like to move on to the next slide. So we know that there may be questions related to COVID-19 in cancer treatment, especially in regards to the COVID-19 vaccine. ASTRO has issued a recommendation on COVID-19 vaccination for cancer patients receiving radiation therapy, which you can read the full statement on astro.org. Cancer patients may have an increased risk of contracting COVID-19 and more severe disease if infected. ASTRO encourages cancer patients who are actively receiving treatment, such as radiation therapy, to consult with their oncologist about the timing for the vaccine, injection location, and any unique considerations relevant for their treatments. Next slide. Be sure to visit RTAnswers.org, our patient education website, for more information on radiation therapy and GI cancers. On it, you will find a full array of information, including brochures and videos on a variety of cancers that you can view online. More information about radiation therapy, questions you should ask your doctor, as well as patient stories from real people who have had radiation therapy. Thank you all for tuning in to tonight's broadcast. As mentioned before, the session was recorded and will be uploaded to the RTAnswers YouTube channel, as well as the RTAnswers website within 24 hours. You can subscribe to the RTAnswers YouTube channel and select the notification icon so you can be alerted about our live streams. You can also follow us on Twitter at RTAnswers_org, RTAnswers_org, as well as Astro at Astro_org. Thank you and have a good evening.